Now I request Dr. Indu VP to present her talk on stars in sky dystrophy, dystrophy or acquired.
Good morning, everyone. I thank Dr. Divya Alex for this opportunity. Now coming to the topic proper, stars in the sky, dystrophy or acquired. So basically stars in the sky means dotted lesions on the retina. Dotted lesions on the retina mainly fall into 5 main categories. These are the flecks, drusen, vitelliform deposits, crystals and inflammatory lesions. So you have plenty of diseases with dots in the sky, with stars in the sky, and how do you differentiate? Differentiation is based on history and course of the disease, clinical features, multimodal imaging, and ERG or EOG tests. Now, we go into one by one in detail. Now, if you have a patient with a positive family history of night blindness, and clinical picture showing plenty of yellowish-white lesions on the retina, and ERG showing raw dysfunction, you are mostly dealing with a condition called flecks. Now, flecks can be, so the first question that you ask when you see flecks is whether it is macula sparing or macula involving flecks. Now, flecks sparing the macula mainly fall into 4 main categories. So how do you differentiate between them? Now, if you have a person with a normal visual acuity, there is no history of night blindness, ERG is also normal, but however, on fundus examination, you see discrete, small flecks distributed throughout the mid-periphery. You are dealing with a condition called a benign familial flecked retina. It is a non-progressive condition. Here, everything is normal, except that on fundus examination, you see flecks. So here, these flecks are hyperfluorescent and autofluorescence. And on OCT, you see mild thickening at the level of the RPE. If the patient has history of night blindness, which is not progressive, that is stationary night blindness, and however, on ERG, patient shows a delayed decreased cotopic ERG after 30 minutes, but which normalizes after 2 hours of dark adaptation. That is, the patient has got a delayed dark adaptation. And if you see plenty of flecks in the mid-periphery, you are dealing with a condition called fundus albipunctatus. It is actually a disorder of visual pigment regeneration where recovery of normal rhodopsin takes much more longer time. Now, if the patient has progressive night blindness, peripheral field loss, and ERG shows both rod and cone dysfunction, and along with that, patient has got an optic nerve pallor with attenuation of blood vessels, that is all features of RP, but instead of the black pigments and you see whitish flecks in the mid-periphery, you are dealing with a condition called retinitis punctata albicans, which is mainly RP with white flecks. Now here again, you can see cystoid macular edema similar to that of RP. Now, if the patient has features of fundus albipunctatus, that is stationary night blindness, delayed dark adaptation, but instead of smaller flecks, you see larger flecks on the retina. This is called as a flecked retina of Cantori. Now, sometimes patients can present with the features of night blindness and peripheral field loss and all, and you see along with that, on systemic examination, you see corneal cirrhosis and white spots, history of inadequate dietary intake or malabsorption. You might be dealing with a vitamin E deficiency syndrome, and this is called as fundus surophthalmicus. Usually, after supplementation of vitamin A, these flecks disappear. So these are the important diseases where the flecks spare the macula. Now we come to the flecks involving the macula. These are actually the true flecks. It mainly falls into 2 main categories. One is the Stargardt's disease and the other is the fundus flavimaculatus. They have a few common features. That is, these flecks are triradiate and they will be intensely hyperautofluorescent, and patients may have a dark choroid and fluorescent angiography. So how do you differentiate? Stargardt's disease is mostly visual involving because of macular atrophy. It has got an earlier onset and there is faster progression. Whereas flavimaculatus, relatively later onset and slow progression. Vision may or may not be affected, may be affected if there are macular flecks. Now, macular flecks can also be seen in a few systemic diseases like Gellin syndrome, ring chromosome 17, and Alport syndrome. Now, coming to the next differential diagnosis, drusen. So, basically, how do you differentiate between a drusen and a fleck? Drusen are usually a later onset and it is progressive, more yellowish in color, rounded, and it mostly situated in the macula. Autofluorescence patterns may vary, and OCT shows it is at a sub-RPE deposit, whereas flecks are usually early onset, mostly stationary, more whitish in color, smaller and regular pattern, may involve macula as well as the periphery, and usually hyperautofluorescent, and OCT shows a thickening of RPE with impingement of the photoreceptor layer. So you have different types of drusen, soft drusen, hard drusen, cuticular drusen, etc. Now, hard and soft drusen, as you can see here, there is hard drusens are usually smaller and soft drusens are larger. Autofluorescence not very significant. And on OCT, you can see that these are sub-RPE deposits. But a cuticular drusen is a characteristic, the fluorescent angiogram of cuticular drusen is a characteristic starry sky fundus. You can see plenty of whitish lesions in the retina. And at OCT, this is a characteristic picture showing the saw-toothed appearance. Reticular pseudodrusen, these are also subretinal deposits instead of the sub-RPE deposits. And on the fundus picture, you see very small, minute lesions which are distributed throughout the macula. And on OCT, you see that these deposits are subretinal and not sub-RPE. Drusen, in addition to age-related drusen, you can also have drusens in hereditary conditions like Malaysia leventinese as well as in MPGN type 2. So these patients will have renal disease also. Now coming to the third differential diagnosis, that is the Whitley-form lesions. Multifocal Whitley-form lesions can also be seen. They may be seen in Best disease as well as in certain other conditions like malignancies. So the most important how to differentiate, they are very intensely hyperautofluorescent like this, and you can also see larger subretinal deposits. And EOG is one of the important confirmatory investigation. Patients with an abnormal EOG will have Best disease. Now coming to crystals, crystals can also produce a starry sky appearance. They may be hereditary or they may be drug-induced. Now if the patient has plenty of glistening, these are glistening yellow deposits throughout the fundus and sometimes crystals in the cornea also, without any systemic disease, you're most probably dealing with a condition called Beatty crystalline dystrophy, which is a hereditary condition. Now here on autofluorescence, you can see multiple areas of atrophy, and on OCT, you can see reflective lesions. These are actually the crystals which are located throughout the retina. Crystals can also be associated with systemic disease like Sjogren-Larsen syndrome, cystinosis, primary hyperoxaluria. So these patients may have, in addition, systemic findings also. Drugs can also produce crystals in the cornea, like for example, nitrofurantoin, tamoxifen, and talc. Inflammatory lesions can also, especially the white dot syndrome, can also produce a starry sky appearance. So what are the clues? They may have associated flu-like illness. Inflammatory signs may be there, like presence of anterior chamber cells and Witt cells. OCT may show patchy outer layer loss as well as subretinal fluid. And the multimodal imaging helps in identifying the diagnosis. So a few examples like mutes, punctating choroidopathy, and APMPP. All these will show whitish lesions in the macula, whitish lesions in the retina. And on the characteristic feature is the ICG. ICG, you can see multiple hypofluorescent lesions on the retina, which are the choroid granulomas. And autofluorescence is another important another important investigation which helps you to identify the diagnosis. So the take-home message is take a proper history and do a proper clinical examination. Multimodal imaging and the electrical test will help in identifying the diagnosis. Thank you.
Thank you, Dr. Indu. That was such